Hi, I am Ajit Virkud, Professor of Obstetrics and Gynecology from Mumbai, India. Hello, citizens of the internet. Today I am going to discuss an important topic, normal labor and its management. I will discuss it in three parts. In the first part, I will discuss the basics and management of first stage of labor. In the second part, management of second stage, and in the last part, management of third and fourth stages. To understand the topic even better, please refer to my textbook Modern Obstetrics. In the last 40 years, there has been a steady decline in the rate of normal vaginal deliveries. This decrease has occurred as a result of changes in the management of several obstetrics conditions, including malpresentation, fetal distress, prior cesarean section, and dystocia. The alarming increase in the rate of cesarean deliveries in modern obstetrics has occurred at the expense of corresponding decline in the vaginal delivery rate. The situation is so alarming that some fear that a day may arise when vaginal delivery will become extinct. To quote Sir T.N.A. Jeffcott, labor can be the most dangerous journey a human ever undertakes. To give you another quotation, life is a journey, not a destination. It begins with birth. Labor is the culmination of pregnancy whereby the fetus, amniotic fluid, placenta, and membranes are separated and expelled from the uterus via the cervico-vaginal canal. When talking about labor, three terms are used: eutosia, dystocia, and oxytocia. You may know the first two, but have you heard about the third term? Dystocia is defined as abnormal or difficult labor, whereas eutosia describes normal labor or childbirth, and oxytocia describes rapid labor. Dystocia is of three types. Maternal dystocia may be bony or cervical dystocia. Causes of fetal dystocia are malposition, malpresentations, and shoulder dystocia. Morbidly adherent placenta and placenta accreta, which can delay the third stage of labor, can be considered as a type of placental dystocia. The clinical definition of normal labor is as follows. Labor is said to be normal, that is eutosia, when a fetus presenting by vertex anterior position is delivered vaginally at full term by natural maternal efforts without undue delay, usually less than 24 hours, and without complications to the mother or fetus. Delivery cannot be said to be normal until the woman has delivered. Hence, labor is normal only in retrospect. Labor is divided into four stages. First stage begins from the onset of labor to full dilatation and effacement of cervix. Second stage extends from full dilatation and effacement of cervix to birth of the baby. Third stage extends from birth of the baby to delivery of placenta. Fourth stage is an arbitrary stage from delivery of placenta until the vital parameters of the mother have stabilized. This table shows the duration of these stages in primary gravida and multipara. First stage of labor is further subdivided into three phases: the latent phase, the active phase. Please note that in modern obstetrics, based on new evidence, active phase starts when the cervix is 6 cm dilated and not 4. Remember, 6 is the new 4. And the transitional phase, which extends from 8 to 10 cm dilatation of cervix. To know whether labor has begun, one must know the signs of onset of labor, which are onset of labor pains, which increase in frequency and intensity as time passes, palpation of uterine contractions which coincide with labor pains, commencing dilatation of cervix, formation of a bag of waters or membranes, and show, which is passage of blood-stained mucoid discharge. This table shows the differences between true and false labor. I am not going into details of the same. Having discussed the basics, I will now talk at length about the clinical management of normal labor. When the woman comes to the receiving room with labor pains, first take her detailed obstetric history, perform a detailed clinical examination which includes general examination, per abdominal and per vaginal examination to ensure that the patient is in labor and not in false labor. Don't forget to review her antenatal chart to look for any high risk factors. If she has a pink card, it suggests that she is a high risk patient. To prepare the patient for a safe vaginal delivery and to carefully monitor any deviation from normal, following preparations are done. Private parts are shaved, evacuation of the rectum by a simple soap water enema, the patient is asked to take a hot water bath, the patient wears a clean gown, a blood sample should be obtained for hemoglobin, grouping cross-matching of 1 unit of blood, and a urine specimen must be obtained for protein and glucose determination. Ambulation is encouraged in a patient in normal labor. Ideally, a partograph must be maintained in every patient in labor, even if everything is normal. Please refer to my separate video on partograph, a link to which is given here. An intravenous line must be kept to tackle any bleeding emergencies that may arise. The patient is encouraged to pass urine from time to time, and if she cannot, an intermittent simple rubber catheterization may be needed to keep the bladder empty. Remember, empty bladder prevents uterine inertia and helps descent of the presenting part. If the patient desires, labor analgesia may be given. Usually, epidural labor analgesia is preferred. For more details, please refer to my book, Modern Obstetrics. I want to make a few comments on cervical dilatation because often mistakes are made by juniors about the degree of dilatation and effacement of cervix. Here I have given two ways to judge the correct amount of dilatation of cervix. One based on the number of fingers, loose or tight, that can be admitted into the cervix, and other based on common eating items. If the cervical opening is the size of a cherry, the cervix is 2 cm dilated. If the diameter is that of a lime slice, it is 4 cm dilated, and if it is 8 cm, it is the size of an orange slice. A fully dilated cervix is the size of a bagel. Before we go on to the management of second stage of labor, one must know the signs of transition from first to second stage. These are increased bloody show, rectal pressure, anal canal dilatation, which is considered as a bearing down sensation, tremors in thighs and legs, and lastly, she feels she is losing control. This is the end of part 1 of my e-lecture on management of normal labor. The link for the second part is given here. For further reading on this topic and other topics in obstetrics and gynecology, refer to the following books written by me: Practical Obstetrics and Gynecology, 5th edition, Modern Obstetrics, 2nd edition, Modern Gynecology, 2nd edition, Clinical Cases in Obstetrics, Questions and Answers, 2nd edition, Clinical Cases in Gynecology, Questions and Answers, 2nd edition, and Pelvic Reconstructive Surgery. If you have found this video useful and informative, please subscribe to my YouTube channel by clicking here.